Part A. In this part of the test, you will hear two different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12.
Good morning, Doctor.
Good morning. Please be seated. Is she your daughter?
Yes, Doctor.
What's her name and what's her complaint?
Her name is Tiara. She gets shortness of breath with vigorous play and exercise. She gets tired more quickly than the children of her age.
Does she have coughing, wheezing, or chest congestion?
No, Doctor.
What's her age?
6 years old, Doctor. Moreover, when she runs in races, she seems to have severe problems, as it seems to take her a significantly long period of time to catch her breath.
Was she admitted to any hospital earlier?
No, Doctor. She needed an apnea monitor after birth, and this was continued for approximately 3 months thereafter. At times, she has nasal congestions during the night and morning hours.
What medications is she taking now?
Nothing, Doctor.
Is she allergic to any medicine?
No, Doctor.
Her immunizations are up to date?
Yes, Doctor, but she is yet to have influenza vaccine.
While her pulmonary function test shows premature ventricular contraction, it is 1.21 liters, that is 77% of predicted. The FEV1 is 1.9, that is 81% of what we've predicted. Peak expiratory flow is 175 liters per minute, that is 82% of predicted. Post-bronchodilator, she has no change in the forced vital capacity, or FEV1. She had a 10% improvement in the peak expiratory flow up to 195 liters per minute. Her forced expiratory flow is 25 to 75% increased to 2.5 liters per second, which is a 28% improvement. Her borderline normal lung volumes as measured by the forced vital capacity and FEV1 and her flows are in the normal range, although there is some improvement seen post-bronchodilator. This would indicate that she has some airway reactivity. I have reviewed her recent chest x-ray. I've also reviewed the echocardiogram report, which shows normal. She has developed dyspnea with exertion, etiology unknown. Maybe reactive airways disease, a potential cause. She has rhinitis, probably vasomotor and infectious. I am going to start albuterol HFA as ProAir and Proventil 2 puffs via Inspir Ease every 4 hours and 15 minutes prior to vigorous exercise. She can use either Claritin 10 milligrams or Zyrtec 10 milligrams daily for rhinitis symptoms, and she may also use Sudafed 30 milligrams every 6 hours for significant nasal congestion. Continue these medications for 2 months and meet me thereafter.
Okay, thank you, Doctor.
Extract 2. Questions 13 to 24.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor. But apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks. If the pulsatile tinnitus does not improve, then I would recommend other treatments, including myringotomy or ear tube placement. You have to undergo for an audio and tympanogram prior to the treatment procedure.
This is the end of Part A. Now, look at Part B.
In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an optometrist talking to a patient who's trying contact lenses for the first time. Now read the question.
Now, you've had the lenses in for a few minutes. How are they feeling?
Not bad. I thought I'd feel them actually touching my eyes, that they'd be sore or prickly, but I can't feel much at all.
Kathy, could you help me with the patient in bed 103? The woman who had surgery 2 days ago.
Oh, yes, she's due for discharge today, isn't she? Does her pain relief need topping up again? I thought she wasn't very comfortable this morning.
Oh, she's on a reasonably low dose, but she's coping. She needs her chest drains removing, though, and she's got herself into a bit of a state.
Ah, well, that's a two-person job anyway, so I'll come with you. Has the consultant seen her? I know there was some concern yesterday about her condition and the level of the fluids draining into the bags.
Oh, he's cleared her for removal of them today, but I think some reassurance might be needed first.
Right. I might just check her analgesia and give her more before we go ahead.
OK.
Question 27. You hear a senior nurse talking about a new initiative that has been introduced on her ward. Now read the question.
One of our key priorities is improving communications between staff, patients and patients' families. We recently introduced a scheme called Dear Doctor, which involves giving each patient a card where they can make a note of any questions or concerns that they themselves have. They can also talk to their families during visiting time, or even on the phone, and see if there's anything else they'd like to add. The cards are then collected and given to the doctor before the ward round. We're really pleased with the response. Patients used to say that they only thought of the things they felt they needed to discuss when it was too late, so the cards give them a better chance to bring up whatever's on their minds. In fact, it's been so successful that we're going to roll it out on all wards in the hospital.
Question 28. You hear two radiologists talking about the type of scan to be given to a patient. Now read the question.
I've just had a phone call from emergency. They have an 11-year-old boy with right lower quadrant abdominal pain. They're concerned about appendicitis, and they'd like to order an abdominal CT for him.
Do you think that's a good idea?
I was thinking maybe we should recommend an abdominal ultrasound, because then we can spare him the radiation.
Is there any concern in this case around using ultrasound instead of CT? Accuracy, for example.
The sensitivity is slightly less than the CT, but the specificity is almost the same, so I think we can rely on the results.
OK. It means we can avoid the child being subject to contrast exposure as well. But what would we do if the ultrasound doesn't answer the question?
If we can't visualise the complete appendix, then we can recommend an abdominal CT.
OK, we have a plan. Call them back and let them know.
Question 29. You hear part of a surgical team's briefing. Now read the question.
OK, next is Mr. Malloy's repeat laparotomy. Any anaesthesia issues? We don't expect any particular problems. He's relatively fit and well, except for his epilepsy, which is under good control. His BMI is 35.
But will we need the obesity bed?
It shouldn't be an issue.
And what about the epilepsy post-operative management?
He's taking his oral medications, and we can use an IV if necessary.
I know he was in a lot of discomfort after his last surgery, and this time he's going to need a larger midline incision. It may be worth thinking about an epidural. He's certainly at the extremely low edge in terms of pain threshold.
Question 30. You hear a senior research associate talking about a proposal to introduce interprofessional primary healthcare teams. Now read the question.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams, groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a presentation by a specialist cancer nurse called Sandra Morton, who's talking about her work with prostate cancer patients, including a man called Harry. You now have 90 seconds to read questions 31 to 36.
My name's Sandra Morton and I'm a specialist cancer nurse, helping cancer patients deal with their diagnosis and treatment. I'd like to tell you about the type of work I do, and particularly about one of my patients, recently diagnosed with prostate cancer. Let's call him Harry, to illustrate the sort of things I get involved with. Now, before we get on to Harry, I'll give you a bit of background. Clearly, my job covers many aspects of patient care, but what's the priority? Firstly, prostate cancer is in fact the most common cancer in men in the UK, with over 40,000 new cases diagnosed every year. That's a staggering number. One problem is that this type of cancer actually develops very slowly, so there may be absolutely no sign that you have it for years. So, if we're going to reduce the number of cases, it's vital that people like me get the word out to as many men as possible, that we tell them how to spot the signs of prostate cancer, like an increased need to urinate or straining while urinating. Unfortunately, the cancer can be at an advanced stage by the time patients come in for tests, at which point the available treatments are far less effective. So, let me tell you a bit more about my patient Harry. Like many middle-aged men, Harry was offered a routine health check at his local doctor's surgery. As far as he was concerned, he had no particular health problems or obvious symptoms at the time, and so he almost ignored the invitation. But he'd promised his family he'd look after himself. His wife had died of ovarian cancer some years before, so he felt obliged to go. It was during his appointment that, based on a few symptoms he mentioned, Harry's doctor decided that he'd need further investigation for prostate cancer and referred him to a specialist clinic at the hospital. Harry's trip to the clinic started with a routine blood test, which initially showed a slightly low haemoglobin level. A further test then revealed that his PSA, the prostate-specific antigen, was high at 20. He then saw a urology consultant who conducted a digital rectal examination and biopsy, a procedure that I always try to explain to patients may be uncomfortable but is entirely necessary. In fact, though, Harry said the 3-week interval between having a biopsy taken and hearing the outcome was far more of an ordeal. Harry told me that when he went to see the consultant to get his results, he immediately sensed he was in trouble. Although the consultant was very considerate in delivering the news, unfortunately the indications were that Harry did indeed have prostate cancer. He was assured that the cancer was low-grade and not aggressive. Harry had suspected the worst, and though he'd tried to prepare himself for it by doing some online research, finally hearing that confirmation was still a shock. In fact, the very mention of the word sent Harry into panic, which was very unlike him. So at the time I first met him, he was very vulnerable and grateful to have someone to talk to. Of course, the response to the illness amongst prostate cancer patients like Harry can vary enormously. I've dealt with some men, for example, who haven't really realised the importance of keeping up their medication because they've felt relatively well, especially if they've been experiencing unwanted side effects. Unfortunately, though, any break gives the disease the perfect opportunity to spread into the bones, making it much more difficult to treat and a successful outcome less likely. And some treatments do cause some unfortunate effects, such as erectile dysfunction, which some men really feel uncomfortable discussing, because it's a sensitive issue. Other patients have mentioned that even though they've been given a lot of help, it's still difficult to weigh up the pros and cons of the various treatment options they're offered, from ultrasound or radiotherapy right through to radical prostatectomy. So responses like these need to be taken into account by specialist nurses when talking to patients. For me, these factors really underline the importance of the community follow-up clinics we have in my area, which address many of these issues in the provision of healthcare for cancer patients. Staff at these clinics see patients during their recovery and only send them back to hospital for treatment if they develop significant new symptoms. Seeing patients in the clinics means that staff get to know each patient and build a relationship with them, which enables nurses like me to dispense advice and answer questions. And although we have no firm evidence, staff feel that's far more beneficial to patients than attending a large hospital clinic. So we're hoping more clinics like these can become available.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a neurologist called Dr. Frank Madison giving a presentation about the overuse of painkillers. You now have 90 seconds to read questions 37 to 42.
I'm Dr. Frank Madison, and I'm a neurologist with a special interest in the overuse of painkillers, particularly of opioids, something experts are now calling the silent epidemic. Now, we've all seen the stereotypical images of addicts hooked on recreational drugs, but addiction to painkillers like opioids has a much less familiar public face. From what I've seen, one reason for this is that the range of people affected makes them less easy to pigeonhole. I mean, there's no typical age, social class, and so on. And of course, most people seeking help for opioid overuse were initially prescribed the medication by their own doctors for pain relief. This highlights a major part of the problem. Physicians often pay little attention to the possible risk of addiction. They need to look carefully at patients' personal histories and assess the risk, considering things like depression and anxiety disorders, before prescribing opioids. In recent years, there's been a dramatic increase in opioid prescriptions. I see a pattern not just of GPs overprescribing, but of GPs inappropriately prescribing. Sure, people want their pain relieved immediately, that's understandable, but proper pain management requires lengthy face-to-face input, which time pressures don't allow, so easier alternatives have become the default option. What's more, although opioids can provide effective relief in the short term, they shouldn't be the automatic first-line therapy. Many alternatives do exist, and they're no more costly. People generally think of pain as a direct symptom of a problem in the affected area. But pain is an extremely complex subject, and it's one that used to be underrepresented in medical education. Thankfully, that's no longer the case, and doctors now realize that when a patient complains of acute back pain, that pain may not be due to a clear and treatable disease, but that such pain often presents in people with other medical problems, and these need investigation. Although there are distinct types of physical pain, all too often, I see sufferers lumped together in one category, which means that unfortunately, not all treatments are going to work equally well. For example, we first need to know, is the pain caused by inflammation as opposed to nerve damage? Establishing this makes initial mistreatment far less likely, meaning that treatment is more effective and the risks of long-term problems are reduced. But it's not just opioids we need to watch. Patients often self-treat with readily available painkillers like paracetamol, and while such drugs play an essential role in pain management, people still need to know more about them. We've been pretty successful in publicizing the dangers of accidental overdose, and clear information's given about the effects of taking these drugs long-term, so public awareness about increased tolerance levels is also gradually improving. Many doctors also now actively warn patients about the spiral of taking higher and higher doses for pain relief. Worryingly, though, I've seen cases where people on drug regimes for other conditions inadvertently take painkillers which add a potentially hazardous ingredient to the mix already in their system. This is something which needs urgent attention. I'd like now to talk about an osteoarthritic patient who was referred to me, a 30-year-old woman, let's call her Anne, suffering from sarcoidosis, an autoimmune disease leading to chronic organ inflammation. She was prescribed various drugs, but though the disease was soon brought under control, the pain lingered, with Anne gradually becoming dependent on prescription opioids. Typically, she was terrified of stopping them, yet the more she took, the worse she felt. The thing is, her prescription would have been ideal for short-term pain, like that following surgery, but should never have been given for the chronic pain she was experiencing. And we all know that living with medication dependency has devastating consequences, not only on social well-being, but also on ability to function professionally, as was the case for Anne. She eventually went on long-term sick leave, as often happens in such cases. Thankfully, Anne's now much better. Having recognised her dependence, and with the necessary support, tools and techniques, she's now off painkillers. The crucial thing is to prevent dependence in the first place. Anne's GP prescribed opioids in good faith, aiming at pain reduction, but failed to set an end date for these. He hadn't anticipated the possibility of eventual drug reliance, this being new territory to him. Anne couldn't hide the visible results of the quantities she was eventually taking, so her GP questioned her about intake. She reluctantly admitted supplementing her prescription from sources like friends and family, something her GP had suspected but hadn't investigated. Anne now realises that drugs weren't fixing her problem, and though withdrawal took several tough months, her determination to succeed has paid dividends.
That is the end of Part C. You now have 2 minutes to check your answers.